Hi folks, this is Dr. Patil and in today's video we will be discussing Sjogren's syndrome, a small but a very important topic for NEET super specialty. Okay, let us begin the topic with a basic understanding of Sjogren's syndrome. What is Sjogren's syndrome? This is a autoimmune disorder that is mainly affecting the exocrine glands. Now we are very much familiar about various other autoimmune disorders which predominantly affects the endocrine glands. For example, Hashimoto's thyroiditis or Graves' disease, type 1 diabetes mellitus. So this is an autoimmune disorder which dominantly affects the exocrine glands. We are already familiar about the exocrine glands that are affected by this, right? Lacrimal gland manifesting with dry eyes and the salivary gland, right? The involvement of salivary gland and lacrimal gland is characteristic. Right? And if you do the biopsy of these affected glands, what we notice is that there is lymphocytic infiltration, right? So that summarizes the Sjogren's syndrome, autoimmune disorder of exocrine glands characterized by lymphocytic infiltration. Right? Okay, now if you look at the epidemiology of this disease, one thing becomes very clear that this is primarily a disorder of females, right? It is primarily a disorder of females. So if you look at the gender ratio, for every one male affected with the Sjogren's syndrome, there are 9 females, right? So female to male ratio is 9:1. And a typical patient who presents with Sjogren's syndrome probably is going to be a middle-aged female, right? A middle-aged female. If you talk about the age range, it would be like 40 to 60 years of age. That is the age range. And if MCQ is specifically asking you about the peak age of presentation, that is usually after menopause, somewhere in mid-50s. Right? Mid-50s is the peak age of presentation. And if you look at the genetic factors which are associated with increased risk, we should remember certain HLA variants. Obviously, we're talking about an autoimmune disorder, so we have to remember certain HLA variants and non-HLA genes which are characteristically associated with high risk of developing autoimmune disorders, right? Okay, so HLA-DQA1-0501 is one HLA variant that Harrison specifically mentions about. So I want you to remember with the exact numbers. HLA-DQA1-0501, right? It is associated with high risk of developing Sjogren's syndrome. Other than that, HLA-DR3 as well as HLA-DRW52. These are also associated with high risk of developing Sjogren's syndrome. Okay. If you talk about the non-HLA genes, that includes IRF5 and STAT4. Right? Certain single nucleotide polymorphisms in these locations, right? IRF5 and STAT4 are associated with the high risk of developing Sjogren's syndrome. That is about genetics. Now coming to disease proper, the Sjogren's syndrome is divided into two types. The primary Sjogren's syndrome, where the exocrine gland involvement is occurring in isolation without the involvement of other autoimmune disorders. When the Sjogren's syndrome or the involvement of exocrine gland is associated with the presence of other autoimmune disorders, we call it as secondary Sjogren's syndrome, right? So primary means it is occurring in isolation, right? It is occurring in isolation. Secondary means it is associated with other autoimmune disorders. What are the autoimmune disorders it is associated with? It includes rheumatoid arthritis, SLE, systemic sclerosis, vasculitis, and mixed connective tissue disorder. Yes, also chronic hepatitis C is associated with the risk of developing Sjogren's syndrome, right? We are very much familiar about that. Now, if the MCQ is asking you what is the most common disorder that is associated with secondary Sjogren's, then it is rheumatoid arthritis, right? Rheumatoid arthritis is the most common disorder responsible for patients developing secondary Sjogren's syndrome. Okay, so this is an MCQ point I want you to remember. Now coming to pathogenesis, right? Coming to pathogenesis, we guys already know that there is some genetic role and probably there is some role of environmental factors. So various infections have been incriminated in the pathogenesis of Sjogren's syndrome, like certain viral infections. And I particularly want you to remember that tuberculosis, very relevant from the Indian context, right? Tuberculosis has also been implicated in the pathogenesis. So genetic factors, we guys already know certain HLA genes, particularly HLA-DQA1. Other than that, DR3 and DRW52, those genetic factors. And environmental factors, infections, particularly tuberculosis. Somehow, through an intricate pathogenetic mechanism, they trigger autoimmunity where there is activation of lymphocytes. Currently, what we understand is probably there is an important role of interferon alpha in triggering the activation of the lymphocytes. Okay, so once the lymphocytes are activated, right, the activated lymphocytes, remember, they are characterized by overexpression of BAF. Right? They are characterized by overexpression of BAFF or BLIS, right? B lymphocyte stimulant factor. Right? There is overexpression, and these activated B lymphocytes produce the autoantibodies. So we know that certain autoantibodies are characteristically associated with Sjogren syndrome. They are not very specific because they can be seen in other disorders like SLE and rheumatoid arthritis and all. But they are, I can say, relatively specific. I can't say that they are definitely specific, but they are relatively specific, like anti-Rho or anti-La antibodies, right? These patients also have other autoantibodies like RA factor as well as ANA. RA factor as well as ANA. Now, when it comes to antibodies, remember, anti-Rho is definitely more common than anti-La, right? Anti-Rho is more common than anti-La. Right? So remember, you can simply remember that anti-La is Mukesh Ambani's tower, right? So that is very rare. There is only one piece. So you can say anti-La is less common, right? And also remember that usually anti-La doesn't occur in the absence of anti-Rho. So when we go to discuss the diagnostic criteria, you will remember this fact. Right? Anti-La doesn't occur in the absence of anti-Rho. Right? Anti-Rho may be associated with the co-presence of anti-La, but anti-La doesn't occur in the absence of anti-Rho. Okay, that is about antibodies. How exactly these antibodies cause the organ or the gland dysfunction is not very clear as of now. Okay. On the other side, there is also lymphocytic infiltration of the exocrine glands. Right? And this lymphocytic infiltration is the one important factor that is responsible for increase in gland size. The gland size increase is mainly because of this. It is not because of the gland hypertrophy. Right? It is because of the cell infiltration. Okay. And also remember that the lymphocytes that are infiltrating are predominantly CD4 positive cells, because we have a mimicker of Sjogren syndrome in HIV patients where the cells that are infiltrating are CD8 positive. Right? So here they are CD4 positive. One important histopathological differentiating feature that we should remember this point. Now all this put together, antibodies in whatever mechanism they are responsible for causing the gland dysfunction plus the lymphocytic infiltration causes the exocrine gland dysfunction, right? That manifests depending on what glands are dysfunctional. We have the clinical manifestations. If it is affecting the lacrimal glands, that causes keratoconjunctivitis sicca. If it is affecting the salivary glands, that causes xerostomia. Sometimes affection of the mucosal glands can cause nocturnal cough. That is one of the common complaints of these patients. And affection of the mucosal glands of the skin can also cause xeroderma, right? So these are the clinical manifestations, right? So point to note, the HLA variants, the role of interferon alpha in the pathogenesis, and also the fact that BAF is overexpressed in patients with in the B lymphocytes in these patients, because treatment is now being directed against that. Like, we don't have any candidate drug which has already cleared the phase 3 trials and is into market, but drugs are under trial which are targeting the BAFF expression, right? Like belimumab. Okay. Now, this is another slide from one of the classical textbook that summarizes whatever we have already discussed, right? So I have already told you that interferon alpha plays an important role in the pathogenesis, right? And that is involved in B cell activation. There is overexpression of BAF. There is also involvement of T cells, right? Obviously, CD4 positive T cells, which cause the glandular dysfunction, right? Which causes the glandular dysfunction. That is the pathophysiological mechanism. Now coming to the clinical manifestations of these disorders, right? So depending on what glands are dysfunctional, clinical manifestations are dependent on that, right? A very common manifestation are basically xerostomia and dry eyes, right? If you are to ask me which one of these has more specificity towards the diagnosis of Sjogren, obviously xerostomia, because dry eyes, there is more longer possible list of other differentials, right? Okay, keratoconjunctivitis sicca. How do these patients present? The patient's presentation is usually in the form of gritty or foreign body sensation in the eyes. And because there is decreased tear production, they feel that there is some gritty sensation or a sandpaper-like sensation behind their eyelids. Right? That is one of the common complaints. And that is because of the decreased tear production. And very often this also makes them photosensitive. And as a consequence of dry eyes and repeated injuries, patients may develop keratitis, corneal ulcers, right? They may develop keratitis and corneal ulcer. Now, how do we diagnose keratoconjunctivitis sicca? Basically, we have to prove that patient's tear production is inadequate, right? So we have various methods. One thing that we are all familiar with is Schirmer's eye test. Right? The other thing we can do is tear breakup time, or we can also try to demonstrate the tear lysozyme content, that it is low. These are three commonly practiced things. Particularly, I want you to remember Schirmer's eye test and tear breakup time. Right? These two particular points. Now, Schirmer's eye test. How do we do that? We basically take a filter paper, place it in the lower conjunctival sac. Right? We place it in the lower conjunctival sac and usually read the to what extent or what length this filter paper has become wet. Right? We read it at 5 minutes. Right? We read it at 5 minutes. Right? We read it at 5 minutes, and at 5 minutes, normally what is expected? The tear film would be wetting the filter paper by more than 10 millimeters. At 5 minutes, tear film will be wetting by more than 10 millimeter. That is normalcy. Right? When it is less than 10 millimeter, it is abnormal. But for the diagnostic purpose, right, what we follow is, if it is less than 5 millimeters at 5 minutes, 5, right? Easy to remember, 5. That satisfies the fact for the diagnosis of Sjogren's syndrome. Or okay, I shouldn't call it a Sjogren's syndrome as of now. You can say that satisfies the criteria for diagnosis of keratoconjunctivitis sicca. Right? That satisfies the diagnostic criteria for keratoconjunctivitis sicca. Less than 5 millimeters at 5 minutes. Okay. Now, what else we can do? We can do tear breakup time. What is tear breakup time? Tear breakup time is the time taken for first dry spot to appear on the cornea after complete blinking. Right? You blink, then hold on without blinking, and we will see what is the time it takes for the first dry spot to appear on the cornea. Okay. Now, less than 10 seconds is considered abnormal. Okay. If it is more than 10 seconds, it is normal. If it is less than 10 seconds, it is abnormal. Okay. How do we do this? Basically, we do this under slit lamp examination. What we do is we put some fluorescent eye drops, and that will coat the cornea. And then we will see what time it takes for that fluorescent eye drops to disappear from the cornea. Right? That gives us an idea about the tear breakup time. Like if there is a proper tear film coating it, then whole fluorescent dye would be coating the cornea. And once that there is a breakup appearing, that time we will be taking into consideration. If that time is less than 10 seconds, then it is abnormal, right? That goes in favor of the diagnosis of keratoconjunctivitis sicca. Now, coming to the next organ involvement, that is the salivary gland involvement. So, salivary gland involvement usually manifests in the form of dry mouth or xerostomia, right? So, how do the patients present? Patients present with difficulty swallowing dry food. Right? Typical presentation, difficulty swallowing dry food, right? And because of the decreased saliva, we know that it is not only saliva is not only going to wet the food, they are also contributing to various other functions or purposes, right? They have lysozyme, which kind of has antibacterial property, right? And that prevents certain oral infections. So patients with xerostomia are prone to develop oral candidiasis, right? They have increased risk of developing oral candidiasis. They are prone to develop dental caries. And if you examine these patients, the salivary gland is usually increased in size. We see that increased salivary gland in 2/3 of the patients, right? Like you can appreciate in the image. The salivary gland is increased in size. And I've already told you the reason behind this increased salivary gland size, right? It is because of the lymphocytic infiltration. Now, how do we diagnose this? The diagnosis is based on cyanometry, and we can also do a labial biopsy, lip biopsy, right? This is one of the important MCQ point. Preferred site for taking the biopsy in patients with Sjogren's syndrome. That is the labial biopsy or lip biopsy, because we are basically trying to demonstrate the lymphocytic infiltration of minor salivary glands, that it is easily accessible, and we don't need to do a major salivary gland biopsy, right? So labial biopsy is the most common site, and if you do the biopsy, you will notice that there is lymphocytic infiltration. Basically, T lymphocytes, mainly CD4 positive cells, right? Mainly CD4 positive cells. Okay, that is about xerostomia. Right? What do we appreciate in this image? This is the lip biopsy or labial biopsy report, and you can clearly appreciate the minor salivary glands. Right? You can appreciate the salivary gland, you can see the glandular tissue, and you can also appreciate the lymphocytic infiltration of various sites, right? Very, very characteristic. Now, one thing we should remember is that these cells are CD4 positive. In HIV associated with Sicca syndrome, it could be CD8 positive. And then we should also remember that there is a very closely related differential diagnosis, that is IgG4 related sialoadenitis, what was previously known as Mikulicz disease, right? So there is also lymphocytic infiltration in Mikulicz disease, but those cells are going to be IgG4 positive, right? The cells are going to be IgG4 positive. So in case of Mikulicz, I want you to remember one particular point. In case of Mikulicz, there will be lymphocytic infiltration of IgG4 positive cells, and the cell number is something that I want you to remember, right? So the cells will be more than 100 per high power field. When it comes to the salivary gland biopsy, obviously for the IgG4 related disorders, we have organ specific criteria or organ specific cutoffs for the IgG4 positive cells, right? So in this case, in case of the salivary glands, it is more than 100 per high power field. Okay. And this is something that is very, very important for differentiation, because they also present with the enlargement of salivary glands, right? And xerostomia. They can also have the lacrimal gland involvement, and they can also have the dry eyes. Okay. Now, coming to extraglandular manifestation. So remember, it is not only restricted to, the disorder is not restricted to the salivary gland and lacrimal gland. So there are also involvement of extraglandular organs or tissues, right? So these extraglandular manifestations can be divided into non-specific, periepithelial, lymphoma related, and immune complex deposition related. So 4 subcategories under this heading of extraglandular manifestations. Okay. Talking about non-specific, yes, patients can develop myalgia, patients can develop arthralgia as well as arthritis. Arthritis can be inflammatory but usually non-erosive, right? It can be inflammatory but usually non-erosive, and patients can also develop Raynaud's phenomenon, right? These are the non-specific manifestations. If there is an MCQ asking you what is the most common extraglandular manifestation in Sjogren's syndrome, that is arthralgia or arthritis, right? Remember this point. Arthralgia or arthritis is the most common extraglandular manifestation. It is the most common extraglandular manifestation. Okay. Now, what are these periepithelial complications? In periepithelial complications, basically there is epithelial or periepithelial infiltration of the non-exocrine organs, right? So we were talking about this lacrimal or salivary so far, right? Other than that, if other organs are also suffering because of the lymphocytic infiltration, then we call them as periepithelial, right? What organs are affected? Lung, right? In lung, the involvement is usually in the form of lymphocytic interstitial pneumonia. Lymphocytic interstitial pneumonia. Yes, I do agree that these patients are prone to develop interstitial lung disease also, where it is usually NSIP pattern, right? Where it is usually NSIP pattern. But other than that, the characteristic lung lesion in patients with Sjogren's is lymphocytic interstitial pneumonia. Okay. The liver involvement is mainly in the form of primary biliary cirrhosis. These patients are prone to develop primary biliary cirrhosis. Now, kidney involvement, I am talking about periepithelial, right? So, lymphocytic infiltration of the kidneys can manifest in the form of interstitial nephritis. It manifests in the form of interstitial nephritis. And when they develop interstitial nephritis, the clinical outcome of that is patients developing distal tubular acidosis or type 1 renal tubular acidosis, which causes hypokalemic hyperchloremic acidosis, right? Hypokalemic hyperchloremic acidosis. So basically it is a type 1 renal tubular acidosis, or you can call it as distal renal tubular acidosis, right? So these are the periepithelial complications. What are the immune complex mediated complications? It can cause small vessel vasculitis, right? It can cause small vessel vasculitis, which very often manifests in the form of purpura. Remember this point again, because a lot of MCQs have appeared in the past where some clinical context is given to make you think that this is a Sjogren's syndrome, and then they give an image where the patient has purpura, right? So that is one important point to note. Apart from that, immune complex deposition can also lead to peripheral neuropathy, right? The neuropathy that we see in these patients is usually either sensory, usually without ataxia, like non-ataxic sensory neuropathy, or it is sensory motor neuropathy, sensory or sensory motor neuropathy. If you talk about sensory, yes, it's usually affecting the small fibers, right? Small fibers neuropathy. Okay, it can also cause glomerulonephritis, immune complex deposition leading to glomerulonephritis, which is more or less in the form of membranoproliferative glomerulonephritis. So, two kidney complications to note. We have already understood that it can cause interstitial nephritis manifesting in the form of distal renal tubular acidosis. Other than that, patients can also develop membranoproliferative glomerulonephritis because of the immune complex deposition. Okay. Now, Sjogren's syndrome is also considered as an important risk factor for development of lymphomas. So, patients can develop lymphomas in the form of maltomas and B lymphomas. So, B cell lymphomas are more characteristic. They are mostly non-Hodgkin's lymphoma. If you have to be a little more specific, they are marginal cell or marginal zone B cell lymphomas, right? Okay. Then I also want you to remember certain important pointers towards the risk of developing lymphomas. What are the pointers? If there is persistent salivary gland enlargement, or if there is low C4 levels, or if patients have cryoglobulinemia, these are the pointers that suggest increased risk of developing lymphomas, right? Persistent salivary gland enlargement or low C4 levels, or patient already having cryoglobulinemia. These are the risk factors that suggest that patient is prone to develop lymphomas or malignant transformation. Okay, that is about the malignancies. Now coming to differential diagnosis. Now if you open the textbooks, you will see a lot of differential diagnosis because all these symptoms that we see, xerostomia, has its own set of differential diagnosis. Like for example, treatment with atropine that can increase the dryness of the mouth, or drugs which have atropine-like properties. Similarly, there are important differential diagnoses for dry eyes. But when it comes to the context, when patient has xerostomia plus dry eyes and has the anti-La or anti-Rho antibodies, the differential diagnosis kind of gets very, very narrowed, right? So I personally consider that there are only important 3 or 4 differential diagnoses that we should know. One is HIV associated with Zika syndrome. Sarcoidosis comes very close in terms of clinical presentation, and the third one is IgG4 related diseases, right? These 3 I consider as important differential diagnosis, and today we will understand how to dissect, how to reach the diagnosis. Okay, if you look at HIV associated Zika syndrome, HIV associated Zika manifestations, usually the disease mainly affects young males, right? Young males. Obviously, young males are more prone to develop the HIV infection per se, right? In case of Sjogren's, we already know it is middle-aged women who are more affected. And if you talk about sarcoidosis, there is not much of a age or gender predilection, right? There is not much of age or gender preference. Then, autoantibodies, which are anti-La or anti-Rho, are very characteristically associated with Sjogren's. We don't see autoantibodies in case of HIV associated Zika as well as sarcoidosis. Sarcoidosis can also cause bilateral parotid enlargement. Sarcoidosis can also cause dry eyes, right? That is why we are considering it in the differential diagnosis. If you do the biopsy of these affected organs, right, biopsy kind of solves the differential doubt, right? If you do the biopsy, in case of HIV associated, I have already told you that patients would be showing the lymphocytic infiltration where the cells are predominantly CD8 positive, right? In case of Sjogren's, they are CD4 positive. And in sarcoidosis, basically we see their non-caseating granulomas, right? There will be granulomas, which are not seen in case of Sjogren's, which are not seen in case of HIV-associated Zika. And if at all you're doing their HLA study or HLA variant study, you will notice that HLA DR5, right? Some patients who have HLA variant DR5 and they have HIV infection, their chance of developing the Zika manifestation is high, right? So HLA DR5 is associated with HIV-associated Zika. On the other hand, DR3, DRW52 and DQA1 are associated with Sjogren's, and such HLA association has not been documented so far in case of sarcoidosis, right? So this is about the differential diagnosis. One differential diagnosis omitted is IgG4 related diseases, right? Mikulicz disease. That is usually not confusing nowadays because usually the IgG4 related disorder will also have evidence of the IgG4 related disease in other organs. For example, autoimmune pancreatitis, autoimmune hypophysitis, or primary sclerosing cholangitis. And because of that, it is, according to me, it's not a very important differential diagnosis as of now. Okay, only when it presents in isolation, where there is involvement of salivary gland or the Mikulicz syndrome kind of presentation, yeah, then it becomes an important differential diagnosis, and biopsy kind of solves the doubt. When you do the biopsy, there we notice that there is IgG4 positive cell infiltration, and there should be more than 100 such cells per high power field, as long as we are talking about salivary gland biopsy. Okay, that is about the differential diagnosis. Now coming to diagnosis. How do we diagnose? Well, diagnosis is definitely based on the clinical context, but a lot of physicians tend to follow the ACR-EULAR classification criteria. We guys already know the difference between the classification and diagnostic criteria, but we generally follow this classification criteria because it makes the diagnosis also a little more easier, or we feel confident after we classify a case as having a particular disorder, right? Okay, what are the components of this classification criteria? We definitely need the labial salivary gland biopsy. So it is mandatory for classifying the case as having Sjogren's syndrome according to the 2016 ACR-EULAR classification criteria. Right? Salivary gland biopsy is mandatory, and obviously we are talking about the labial minor salivary gland. Right? So in that, what do we document? Focal lymphocytic infiltration, and there are certain histopathological terms like the focus score of more than or equal to 1 foci per 4 millimeter square, right? That gives a point of 3 score to the patient. And patient having anti-SSA, or the another name for that is anti-Rho antibody positivity, that gives the patient 3 points, right? Now, one particular point I want you to note, that this scoring system only talks about anti-SSA or anti-Rho. This is because I have already told you when we were discussing the other slides that anti-Rho usually occurs, it is more common. The anti-LAR doesn't occur in the absence of anti-Rho, right? That is why they only talk about anti-Rho in the classification criteria. They also talk about the involvement of lacrimal gland, and the criteria that is followed here is basically ocular staining score at more than or equal to 5. Or as an alternative to that, you can also follow Van Bijeserveld score. I don't know if I'm pronouncing it right, but that is what it sounds like, right? If that score is more than or equal to 4, in at least one eye, patient gets 1 point. And then we can also rely on Schirmer's eye test, red at 5 minutes, less than 5 millimeter wetness, at least in one eye, patient gets 1 point. And they also talk about unstimulated whole saliva flow rate of less than or equal to 0.1 ml per minute, patient gets 1 point. If patient gets a score of more than or equal to 4, if the patient gets a score of more than or equal to 4 and he meets all the inclusion criteria and is negative for all the exclusion criteria, then you can classify the case as Sjogren's syndrome, primary Sjogren's syndrome, right? Okay, so what are these inclusion criteria? Remember, patient should have satisfied the inclusion criteria, right? It should be meeting the inclusion criteria. Okay, what is the inclusion criteria? Inclusion criteria says patient should have at least one symptom of oral or ocular dryness, which is defined as positive response to any of the, at least one of these following questionnaires. So patient should have at least one symptom of oral or ocular dryness, oral or eye dryness, at least one symptom should be there. But how do we get to know? For the inclusion criteria, we're not quantifying, rather we are putting out 5 questions to the patient, and patient should be saying yes to at least one of these questions, right? That is the inclusion criteria, and this should be met. Okay, so what are these questions? Daily persistent dry eyes for 3 months. So we will ask the patient, do you have persistent dry eyes daily for last 3 months? Yes. Well, inclusion criteria is satisfied. Similarly, we will also ask if patient has got recurrent sensation of sand or gravel in the eyes, right? The third question is also about the eye, requiring tear substitutes more than 3 times a day, right? To feel comfortable, if the patient is requiring using the artificial tears for more than 3 times a day, right? First 3 questions are about the eye involvement. The next 2 questions are about the xerostomia, right? Whether the patient needs daily feeling of dry mouth, whether patient has daily feeling of dry mouth lasting for more than 3 months, or whether patient needs frequent drinking of liquids to facilitate swallowing of dry food, right? So if the patient's response to any of these questions is yes, right, one or more than one questions he says yes, that satisfies the inclusion criteria. Once we have made sure that inclusion criteria is met, we should make sure that all the exclusion criteria are ruled out. What are the exclusion criteria? Exclusion criteria are basically the disorders which can mimic the Sjogren's syndrome. So that includes history of head and neck radiation. History of head and neck radiation. Obviously, that actually causes the atrophy of these lacrimal and salivary glands, and that explains why these patients may experience dryness of mouth and lack of tears, right? So that should be ruled out. So if there is exposure, that patient has been treated in the past for head and neck malignancy or whatever indication, he has received radiation, then that is an exclusion criteria. So we exclude the case from the classification. We don't call that case, or we don't classify that case as Sjogren's syndrome. Similarly, active hepatitis. So when we were discussing the causes, right, I did tell you that active hepatitis C is associated with sicker manifestation. So we consider it as an exclusion criteria here. Other than that, we are already familiar that HIV can also cause similar manifestations. We know the differential diagnosis, how we differentiate. So if that is present, the case is excluded, right? Then another differential we discussed was about sarcoidosis, right? Okay. Apart from that, I also want you to remember three more things: amyloidosis, graft versus host disease, and IgG4 related disease. We have already elaborated about the IgG4 related disease as a differential diagnosis. So if patient has met any of these diseases diagnostic criteria, then the case is excluded. So when inclusion criteria is met, all the exclusion criteria are excluded and patient scores more than or equal to 4 on this scoring system, right? Then we classify the case as having Sjogren's syndrome. Mainly primary Sjogren's syndrome is what I am talking about. Okay, that is about the approach to diagnosis. Now coming to the management of Sjogren's syndrome. Unfortunately, we don't have any effective immunomodulatory drugs. As of now, we understand that interferon alpha plays an important role in the pathogenesis. We also understand that B lymphocyte stimulating factor, or BAF, also plays an important role in activation of B lymphocytes. But unfortunately, most of the trials have not come out with drugs which are effective. Okay, so there is no blanket prescription in case of Sjogren's syndrome also. Currently, what we follow is mainly symptomatic approach, right? Mainly symptomatic approach. So we can prescribe pilocarpine or cevimeline for the xerostomia and the ocular dryness. These drugs mainly help xerostomia more. Right? To some extent, yes, they do help the dry eyes, but mainly they are given or prescribed for tackling the xerostomia. Apart from that, yes, we can also make patients achieve lozenges, non-sucrose containing lozenges to facilitate salivation. Yet, that is one approach. If you talk about the dryness of the eye, right, we can also have artificial tear supplementation, right? Artificial tear drops can be prescribed. And another important thing about the management of these disorders is that we should pay attention to the environmental factors or measures. Like if you're traveling out, you are a case of Sjogren's syndrome, I would be instructing you to wear spectacles, because the wind is an important factor for the dryness of eyes, right? So we can minimize all those environmental influences in the symptoms, right? So that is one additional point that we should be aware about. Well, then there are certain drugs which have shown positive results in some trials and negative results in some trials. But nonetheless, a good number of doctors continue to use them in some subset of patients. Like for example, immunoglobulins, IVIG. IVIG in some studies has shown to be helpful in treating the sensory motor neuropathy. So there are some doctors who continue to use that. Similarly, rituximab. If you have to pick up one drug which has been shown some efficacy, at least in the early stages of the disease, or for the short-term outcome, that is rituximab, right? Most other drugs have failed the trials, right? Rituximab has shown some short-term efficacy in reducing the lymphocyte infiltration and the outcome of symptoms in terms of patient-perceived symptom. It has shown some short-term efficacy. There are studies which have studied infliximab and etanercept, and they were not helpful, right? The studies clearly show that they make no difference in terms of patient-perceived symptoms as well as disease activity. Okay. Then belimumab, what is this? This is anti-BAF or anti-Belis monoclonal antibody, right? So far there is inconclusive data about this drug. Now we understand the role of BAF in the pathogenesis, but the drug has not proven very effective. There are small studies which which are inconclusive, which couldn't prove whether it is helpful or not helpful. So where do we stand? As of now, we stand at a stage where the primary treatment of Sjogren's syndrome is in the form of supportive care, right? If there is organ involvement, if someone is developing interstitial lung disease, yes, you can treat them with the antifibrotic agents and all, but it is organ specific, right? Overall, talking about it, mainly we extend them supportive care, nothing more than that. Okay, that's all from me, guys. I will be connecting to you on another video on another important topic.